Hi everybody. I want you to open up your CPT code books. We're going to go through and put in some notes. So this video will go through all of the notes for the general surgery and then the integumentary system. I start in your CPT books on page 71. Now if you get behind, you can just pause me, get the note written. I'm going to keep going. Starting on page 71, this is the general surgery section in CPT. As you can see, if you turn a page back or two, and the textbook really goes over this well, is the guidelines pages. Guidelines are at the beginning of every section, way at the beginning. They're always green pages, so the pages that are green are the guidelines. If you're stuck in a test, if you are taking a test after you graduate and to get a job, you have to take a coding test sometimes to get a coding position. Go back to the guidelines. Everything's here for you, so make sure you pay attention to those. On page 71, starting with notes, I'm just going to go through really quickly any notes that we need to put in. On page 72 was where I have my first notes in the CPT book. Under debridement, the blue heading there, debridement on page 72, I have as a primary procedure written there, as a primary procedure. Debridement only, I have written there. And I also have written not for ulcers. What any of that means is we usually don't code debridement unless it's the only thing that's done. A lot of times debridement is included. Of course, before we stitch up your cut or wound, we have to debride it or clean the glass out. Okay, if you put your arm through a window. It's kind of a duh. So a lot of times we don't code debridement separately unless it is explicitly stated and unless it's stated as extensive. If you turn the page to page 74. Shaving of epidermal or dermal lesions. I have a note listed here. Full thickness goes to excision. Full thickness goes to excision. And in that paragraph underneath that blue heading there, shaving of epidermal or dermal lesions, I have a little bit underlined. And again, if you make notes in your CPT book, use a pencil. Okay, it's best to use pencil. I have a little star and I have underlined without a full thickness dermal excision. That's part of that sentence there, without a full thickness dermal excision. If it is a full thickness, then we have a note that says go to excision. At the top of that second column where there's a picture of a lady there and it says removal of skin tags, I have written in kind of above that picture, no closure unless more than simple. No closure unless more than simple. A lot of removals and a lot of things we're going to do in the integumentary system and musculoskeletal have a simple removal included in them. So a simple suturing is just a one-layered, okay, putting in stitches or doing the glue, the derma bond. So none of that is coded separately unless it's more than simple. If they have to do a layered closure that's more in depth, we can code those. Okay, and the textbook is really good if you pay attention to go through those. So shaving has its own area. If you look right above shaving, skin tags have their own area. That's one thing you'll start to remember the more we use. Skin tags have their own codes. If anything is shaved, if you see the word shaving, that has its own separate area as well. On page 75, where we start talking about excision of benign lesions, they go through some of the rules here. This reading is really good for you to take time to go through. At the very top picture here, there's kind of a circle with a lesion. I wrote sometimes no margin, exclamation point. There's not always a margin that they take out. There isn't, okay? If you look at these pictures, they show 3 different lesions and 3 different ways of calculating it and how they're removing that lesion. At the very top of the second column is where you really need to underline. The paragraph that says excision is defined as full thickness, so through the dermis, removal of a lesion, including margins, and includes a simple or non-layered closure when performed. I just said that. Report separately each benign lesion excised, so report every single one separately. Here's your big kicker here. Code selection is determined by measuring the greatest clinical diameter of that lesion plus the margin required for complete excision. So the lesion diameter plus the most narrow margins required equals the excised diameter. The margins refer to the most narrow margin required to adequately excise the lesion based on individual judgment. So as you can see in this little tear-shaped picture, the middle picture here, you can see the cut line and the lesion line, right? The margin is how much healthy tissue was taken, just to make sure that they got it all, okay? Down at the bottom of page 75, I have a few terms written. The terms that I have written in here is the word lipoma, L-I-P-O-M-A, lipoma, equals benign. That's a benign lesion, a lipoma. Now, from medical terminology, I think a lot of students can go astray here a little bit. Oma means tumor or mass, right? Doesn't always mean that it's malignant or it's cancerous. We need to be very careful with this, of course, when we're coding. I don't want cancer being put on my medical chart unless I really know that that's what it is, right? I don't want a coder seeing a lipoma, which means tumor or mass, and coding it as a malignant excision. Okay, that's going to start a whole other ball of wax that I don't want in my medical record. A lipoma is in fact benign, unless otherwise stated. A seborrheic keratosis. Seborrheic is S-E-B-O-R-R-H-E-I-C, seborrheic, and keratosis is K-E-R-A-T-O-S-I-S. A seborrheic keratosis is also benign. So I have that written in there. And a regular old keratosis is a benign lesion. And this just comes from learning. And the more you do, the more you learn. I remember visiting with my provider and having him get this straight for me, and then I wrote it down. Turn the page to page 76. Under excision malignant lesions. Again, it tells you exactly how to select the code. In the second paragraph there at the very bottom of the page, kind of in the middle of that paragraph, it says, this is what I have underlined with my pencil, code selection is determined by measuring the greatest clinical diameter of the apparent lesion, plus that margin required for complete excision. I underlined that sentence there in that statement. And then I have, again, a keratosis equals benign, but an actinic keratosis is pre-malignant and codes to malignant. So what type of keratosis is pre-malignant? Is actinic, A-C-T-I-N-I-C. Actinic keratosis comes from the sun, okay? They are pre-malignant, and you do code them to malignant. If you turn to page 78 under nails, that code 11719, I have written normal in quotes. It says trimming of non-dystrophic nails, any number. That's going to the podiatrist and having the nails trimmed. They're not diseased, okay? It's just a normal trim because the patient can't do it themselves. Under 11730, it says avulsion, nail plate, partial or complete, simple or single. I have written will grow back. Under 11750, I have underlined for permanent removal. There, those words underlined. And then right underneath those, I have will not grow back. So permanent removal of the nail. On page 79, repair. First of all, I want you to write 1 inch equals 2.5 centimeters. You write it here. It's good to write it in the very inside flap of your CPT book as well. 1 inch equals 2.5 centimeters. 2.54 centimeters, excuse me. Under repair or closure, it says use the codes in this section to designate wound closure utilizing sutures, staples, or tissue adhesives. I have written there Dermabond. It's called Dermabond or glue. A lot of patients don't agree with that. But if the physician uses the Dermabond or glue, like super glue, okay, to close up your repair or your cut, we charge the same for that as we would stitches. At the top of page 79 on the second column, it says wound closure utilizing adhesive strips as the sole repair should just be coded out with a regular office visit or E&M code. I have written steri strips. We don't bill for doing steri strips. That's not a big deal. I have simple repair circled, intermediate repair circled, complex repair circled. Those are very good to read and go through. Under simple repair, I have underlined simple, 1 layer closure. Under intermediate repair, I have required layered closure. So layered. And complex, you can read about that. The instructions. Okay, at the bottom of that column, I have starred, and then I have circled the number 1, number 2, number 3. Okay, that's showing us, and number 4 over on the next page, on page 80, that is showing us how you can lump together wounds that are in the same body part and at the same complexity. So if I have 2 simple closures in the same body area as one of these codes here, for as in code 12001, simple repair of wounds of the scalp or the neck or the axilla or the external genitalia or the trunk or the extremities, including the hands and feet. If I had a wound that was just a simple closure on my hand and also my scalp, I could add those 2 amounts together and pick 1 code. Okay? Moving on page 82, adjacent tissue transfer or rearrangement. That first big sentence there I have underlined, and I kind of have circled rotation flap. An adjacent tissue transfer means they cut 3 sides of, like I think of a square, 3 sides of the box, but 1 side is still connected, and they just shift it a little bit. So it's still connected, it still has a blood supply. That's the deal with those type of things. Let me keep moving on here. On page 91, code 17110. This is destruction. Benign lesions other than skin tags or cutaneous vascular proliferative lesions. I have written corns or warts. Okay, corns or calluses or warts under 17110. On page 92, under destruction, malignant lesions, any method, I have each. Just the word each written there, so you code for each one. And then behind Mohs micrographic surgery, we talked about that in med term. That's where they go layer by layer and shave off a lesion and go look at it under the microscope and see if we still have bad, cells in there. Come back, shave another layer off, go look at it in the microscope. It takes longer. They go layer by layer to make sure they get all of the mass that they are taking out. And that's all the notes for the general surgery and integumentary system out of your CPT book. If you have any questions, please let me know. Please use a discussion area to ask me questions about the homework, and I'll try to keep on top of making more videos as well.